Hello, and welcome to the Society of Critical Care Medicine's iCritical Care podcast. I'm your host, Dr. Margaret Parker. Today, I will be speaking with Jerry J. Zimmerman, MD, PhD, on his articles, Critical Illness Factors Associated with Long-Term Mortality and Health-Related Quality of Life Morbidity Following Community-Acquired Pediatric Septic Shock, and Trajectory of Mortality and Health-Related Quality of Life Morbidity Following Community-Acquired Pediatric Septic Shock, published in Critical Care Medicine in March 2020. To access the full articles, visit ccmjournal.org. Dr. Zimmerman is Professor of Pediatrics and Anesthesiology and a faculty member and Emeritus Division Chief of Pediatric Critical Care Medicine at Seattle Children's Hospital and Harbor View Medical Center, University of Washington School of Medicine in Seattle, Washington. Welcome, Jerry.
Good morning, Margaret. Thanks for the invitation to present these two articles.
We're happy to have you here. Would you start by talking about the scope of sepsis? How big a problem is it anyway?
So just recently in Lancet, an article examined sort of the global burden of sepsis. And out of this article comes this striking statistic that once every 3 seconds, someone in the world dies of sepsis. And about 40% of these deaths are in children that are under 5 years of age. And for patients who are in the hospital, at least in developed countries, sepsis is the leading cause of death. What's good about children is mortality from sepsis has really decreased considerably in the last several decades. And with that comes this opportunity, sort of what these two articles are about, for researchers, and I would say also clinicians, to begin changing their focus from mortality. Of course, it's still hugely important, but because there are increasing survivors, we can now think about really focusing our attention on what is going to be the long-term outcome, functional status, quality of life in these patients.
Can you tell us about the LAPS study?
So the LAPS study, Life After Pediatric Sepsis Evaluation, was a prospective cohort outcome study. This was designed to address the two specific aims, basically, that are described in the titles of these two articles that we're talking about today. The study was conducted in the United States in 12 academic pediatric intensive care units. Enrollment occurred between July of 2014 and June of 2017. And the children that were enrolled in this study were thought to have highly suspected or actually diagnosed infection. Antibiotics were prescribed to these kids, cultures were taken, and all of these children also were receiving vasoactive inotropic support as an indicator of septic shock. Almost all of these children also required some type of mechanical ventilation support. The study collected information about demographics, illness severity, organ dysfunction, and resource utilization. And then the main focus of this LAPS investigation was to follow functional status and quality of life, in particular over the 1 year following these children's admission to hospitals for the index sepsis event.
How did you measure functional status and quality of life?
For functional status, we used two tools. The tool that most everyone is familiar with is called the Pediatric Overall Performance Category Score, or POPC. This has been well validated in the PICU population. And in addition, we use this other more recently developed tool called the Functional Status Scale. This is actually a much more granular instrument, and it really was designed specifically for use in clinical studies among critically ill patients as a measure of functional status. And we use both of these instruments measuring the children or assessing the children at their baseline at 7 days, and then at hospital discharge or 28 days.
And how about quality of life?
So quality of life, we also used two different measures for different reasons. Most of the children were assessed with this well-known tool, the Pediatric Quality of Life Inventory. This is probably the most validated, at least pediatric quality of life instrument that is available. It really covers the entire spectrum of ages. We also utilize this tool called the Stein-Jessup Functional Status Scale, which really is not just a functional status measurement, but a measure of overall or general health. And we use this tool because some parents of children with significant developmental delay said to us that the questions in the PedsQL just did not make sense for their child. So for that reason, and to ensure that we could really engage these children with significant baseline disabilities, we actually decided to use both tools. This is a liability for the study, some might say, because we did use two different tools. On the other hand, in the end, I think the investigators view this as an asset because we really were able to assess all children in terms of their quality of life with tools that made sense to the parents who were providing these serial proxy assessments of their children.
How many children did you study, and what were your findings?
Well, in total, over this enrollment period between 2014 and 2017, 838 children were screened. Of these, 632 met the inclusion and exclusion criteria, and 90% of these children were approached for enrollment into the study. Ultimately, 392 of these children, or 69% of those that were eligible, were actually enrolled. So we think those are pretty good numbers. Our findings, let me just sort of go through this systematically. First of all, in terms of infectious disease status, about half of these children, 49%, had a documented bacterial infection. 20% of them basically had a viral infection with clinical sepsis. Another 20% had combined virus and bacterial infections. And then 32% of the cohort never demonstrated any positive culture or a positive polymerase chain reaction testing for a virus. Of the 392 participants, we had good representation across the entire age spectrum for children from neonates basically to children up to 18 years of age. About 45% of the participants were female, and 17% of these kids were immunocompromised in some way. In terms of initial severity, these children were assessed with both PRISM as well as the Pediatric Logistic Organ Dysfunction score on day one, with PRISM and PLOD scores of median scores of 11 and 9. The median PICU and hospital days were 9 and 16. The median duration of vasoactive inotropic support was 3 days, and for mechanical ventilation, 8 days. Of this cohort, 38 required renal replacement therapy for a median of 8 days, and 27 required extracorporeal life support, also for a median of 8 days. I think it's notable that at baseline, in terms of gross functional status, only 38% of these kids had a normal functional status by the POPC score. And at the time of reassessment at 1 month, the majority of these children remain below their baseline pediatric cerebral performance category, as well as pediatric overall performance category. And this was ascertained with the functional status score data. Utilizing this instrument at baseline, approximately 50% of these children had a normal status utilizing this instrument, but again, at hospital discharge or 28 days, the majority of these children were abnormal compared to their baseline as assessed following the sepsis event. For quality of life, again, we used 2 instruments. And if you just look at the scores of these 2 quality of life measures, and it's important that both have a scale from 0 to 100. The nadir of quality of life, as you might expect, occurred on day 7, while most of these kids were still in the intensive care unit. If you look at children who were assessed with the PEDS-QL, they mostly, or as a median of the group, were sort of back to normal by 3 months. With a lot of variation, obviously. And interestingly, for the kids with baseline severe developmental delay, as medians, they seem to be, as a group, mostly back to baseline by 1 month. That was an unexpected but interesting finding. And between 3 months and 12 months, there was really very little additional improvement in these quality of life scores. I don't want to forget to mention that one of the big strengths of this investigation was that all of these children were assessed at baseline, or assessed for their baseline functional status or quality of life. So the subsequent measurements at 1, 3, 6, and 12 months all were referenced to this baseline. So for children that were assessed with the PEDS-QL instrument, there was a significant proportion who remained below their baseline quality of life 1, 3, 6, and 12 months with these follow-up assessments, and similar findings were noted for the children who were assessed with the Stein-Jessup functional status score. In total, in-hospital mortality was approximately 9%, and by 12 months, following the sepsis event. Another 4% of these children had died. So 12-month mortality associated with pediatric sepsis is currently 13%. If you combine all of the data related to quality of life, fully 35% of these children still remained below their baseline quality of life at 1 year. This was striking to me. I think it was striking to all the investigators. Sure, most of these kids were getting back to normal, but at least a third of them remained below their baseline. This was noted at 3 months and basically persisted at the 6 and 12-month follow-ups. So there is definitely a large proportion of children who remain below their baseline, even as far as a year out following the sepsis event.
Would you talk about what variables you looked for association with outcomes?
Sure. Let me just define some definitions that we use for this part of the study. For death, we looked at all-cause mortality. Then we looked at this other, I would say, new variable that we call persistent and serious deterioration of quality of life. And we define this using either of the quality of life instruments as persisting more than 25% below baseline quality of life. So we didn't arbitrarily pick thresholds for these instruments. We used each individual's baseline and then watched how these patients' trajectory back towards their baseline happened or didn't happen. And if they remained more than 25% below their baseline, we said this is a serious deterioration of quality of life. And if you combine these two measures, death and poor quality of life, we define this as a poor outcome. So the variables in univariable analysis that we considered as possible associations for these outcomes were severity of illness at admission, utilizing either PRISM or PLOD, the maximal and cumulative organ dysfunction that we measured by PLOD, the maximum and cumulative vasoactive inotropic scores, the duration of mechanical ventilation, the need for rescue therapies like renal replacement therapy or extracorporeal life support or cardiopulmonary resuscitation. We looked at a unique measure, I don't think this has been done before, which was the magnitude of deterioration of functional status that occurred during the first 7 days of ICU admission. We looked at any new pathological, neurologic sign or event. This could be new seizures, a new intracranial bleed, cerebral edema. We looked at ICU duration of stay, and at least for quality of life, we also examined patient age, which was an important variable. In the end, on multivariable regression analysis, and there were many possible models, but within a group of clinicians and statisticians, we chose one that we thought was biologically plausible and clinically relevant. So this final model included the summation of daily PLOD, or organ dysfunction scores, and the risk for a poor outcome was increased by 1% for every PLOD point. Secondarily, the highest vasoactive inotropic score was important because for every point the patient had a 2% increased risk of a poor outcome. And then, as expected for any acute pathologic neurologic sign or event, the patient's risk increased fivefold. So in this model, cumulative organ dysfunction per PLOD, basically intensity of septic shock by the vasoactive inotropic score or any pathologic neurologic event were independently associated, very highly statistically significant with a poor outcome.
Can you tell us about the limitations of your study?
Sure. Well, the biggest limitation of this study was loss to follow-up. This is always a challenge for a longitudinal investigation like this. And we actually had a very experienced team in place to do these follow-ups. And these were conducted, some of them in person, many by telephone, some over the internet, some even using applications on smartphones. So we tried a variety of techniques. We also reimbursed families for their time for doing so. However, the fact of the matter is that at 12 months, we still had only about 50% of the patients that originally had baseline data who remained in the study. So this is a significant liability. What I can say, however, is if you look at the group that dropped off, at least in some ways, they were more seriously ill. Their PLOD scores initially and PRISM scores were pretty close to each other. But in terms of cumulative PLOD scores or for example, mechanical ventilation days or vasoactive support, the group of patients that were lost to follow-up actually demonstrated higher illness severity with these variables. So we chose to use data that was, I would say, solid. We report as our primary outcomes data without imputation, but in the electronic supplement of the second article, we also report data utilizing multiple imputation techniques and plug in values that are missing. And when this is done, the final results are even more striking. That is, a greater proportion of children for a longer duration demonstrate this persistence of poor quality of life over the serial assessments all the way to 1 year. So it's a liability. We address the liability with imputation, and the results are even more striking. So the primary results that we report are probably an actual underestimate of this total burden of poor quality of life following pediatric sepsis.
What are the implications of these studies for clinicians? What should we take away from these two papers?
So I think, at least for me, I guess I should just speak for myself, but when you work in the intensive care unit, one of the goals is to wean these patients proactively off of their support and, get them out of the ICU and out of the hospital. And to date, we've been sort of largely blinded by what happens afterward, although I will say there is increasing evidence of interest in what happens afterward. And I think this study specifically provides quantitative data that all is not well, even though we have rescued most of these patients from their organ dysfunction when they leave the intensive care unit. And just as a something new to think about. In general, at least a third of children surviving their septic shock are not normal with respect to their quality of life. They remain in a clinically significant way below their baseline. And there may be a number of reasons for that. One of the purposes of this study was to really examine this idea of a composite measure for future interventional clinical trials. If you would want to use mortality nowadays as an outcome measure, you would need to enroll many thousand patients in each group if you were targeting a 25 or 20% effect size from the intervention. And this is because mortality is now quite low. But if you utilize this idea of death or a significantly poor quality of life at the follow-up assessment time point, then you have a baseline occurrence of this outcome measure that is somewhere between 25 and 37%, depending upon whether you want to look at 1 month or 3 months. And this is a logistically feasible, it is a clinically meaningful endpoint that I think deserves a closer look. And in fact, the current stress hydrocortisone and pediatric septic shock trial that is about to kick off in the United States will use this approach, that is death or persistent serious deterioration in quality of life as a primary outcome measure. And then lastly, I would just say that in thinking about this poor quality of life following pediatric septic shock, there's two things. One is this a result of the individual disease process? And that is, septic shock in this case. And or does this also almost certainly involve how we take care of our patients? And as you probably know, the adult data from ICU liberation are unequivocal in terms of changing how we take care of our patients by proactively weaning sedation and mechanical ventilation and encouraging mobilization can make a huge difference. So I think there are things that we can do in terms of how we provide general care to critical care to children with pediatric septic shock, and also probably the earliest recognition of infection. And lastly, this poor quality of life is out there in a significant number of patients, and not only primary care physicians should be aware of this, but critical care physicians should be aware as well, because they may be the best information source for a primary care physician as to exactly what people should be looking out for based on what happened in the intensive care unit.
Thank you for walking us through these two very important papers. Do you have any final comments? Where do we go from here?
Yeah, I think, again, I don't have all the answers, but now we have data on what the signal is in terms of long-term morbidity and mortality after pediatric sepsis. And now I think we need to not change our focus in terms of doing our best to resuscitate these patients in the PICU when they come in with sepsis, but we also need to be cognizant of the fact that there is lasting morbidity, and we need to look at ways that we might address that as well.
Thank you very much, Jerry, for talking with us today.
Well, it is my pleasure. I appreciate the invitation. Thanks very much, Margaret.
We have been talking with Dr. Jerry Zimmerman from Seattle Children's Hospital about 2 articles on outcomes after community-acquired pediatric septic shock published in Critical Care Medicine in March 2020. This concludes another edition of the iCritical Care podcast. For the iCritical Care podcast, I'm Dr. Margaret Parker.
Margaret Parker, MD, MCCM, is Professor Emeritus of Pediatrics at Stony Brook University in New York. She is a former president of the Society of Critical Care Medicine. She is currently serving as Associate Editor of Critical Care Medicine and Senior Associate Editor of Pediatric Critical Care Medicine. Join or renew your membership with SCCM, the only multi-professional society dedicated exclusively to the advancement of critical care. Contact a customer service representative at 847-827-6888 or visit sccm.org/membership for more information. The iCritical Care podcast is the copyrighted material of the Society of Critical Care Medicine, and all rights are reserved. Statements of fact and opinion expressed in this podcast are those of authors and participants and do not imply an opinion or endorsement on the part of the Society of Critical Care Medicine, its officers, volunteers, or members, or that of the podcast commercial supporter.